The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone. Thank you for joining us today. My name is Janik Garayev, and I'm the Senior Health Education and Engagement Specialist with Brain Tumour Foundation of Canada, and really appreciate you joining us today for our 9th webinar this year, 9 of 12 webinars that we're bringing to you. Our mission is really to reach every Canadian affected by a brain tumor through either information, education, support, and or research. And this webinar series is really just one way, one educational program that we have and that we offer to our brain tumor community. And so please make sure to check out our website at braintumour.ca for regular updates, and make sure you also follow us on social media as well, because we always have lots of fun things that we're posting there, and lots of resources that we share with the community. And even though our office is closed to the public, we are still here for you. So you can still call our 1-800 number. You can email any of us, or we can video chat with you if you would like. And then just before we get started, just a few logistical things. Everybody is automatically muted for the webinars so that we don't have background noise. Make sure that you do have the sound up. And so make sure you can hear us. And then the webinar is recorded, so we usually upload that within a week or so to the website. And we always email everybody who registered to let them know that it is up on the website in case people miss it, or if you want to go back and watch it again. And we will be taking questions at the end of Mary's presentation. So if you could just take a moment throughout the presentation and add a question or a comment in the chat section, and maybe keep an eye on that section as well, because I'm going to be posting some links there for you also. If by some chance we run out of time for questions, Mary and I will follow up with you via email next week sometime. And so before we get started, I have 3 poll questions for you, actually. So if you can just take a moment and just let us know who is online with us today for this webinar. Are you a patient survivor, a caregiver, family or friend, a healthcare professional, or maybe you're a volunteer for Brain Tumour Foundation of Canada? So I'll give everybody a moment to answer that. Everybody's clicking. Perfect. So it looks like, just as an FYI to you, Mary, about 58% are patient survivors, 8% are caregivers, 25% are healthcare professionals, and 8% are volunteers for Brain Tumour Foundation of Canada. And the second question I have for everybody, and this is to help our marketing team out really, is how did you hear about the webinar series? Was it through one of our email communications, through social media, through a family member or a friend, an online search, or were you referred by a healthcare professional? So once again, I'll give you a second to answer that. Awesome, I love it when technology works. All right, looks like everybody has added their answers. So 56% through email, which is pretty typical for our team. I'm adding a new poll question, and I just want to kind of gauge how everybody's doing during the pandemic here. And so in terms of the pandemic, whether it is change we control or change that is thrown upon us, looking at the scale below, where would you place yourself right now during the pandemic, and how are you coping? And the reason why we're asking this question is, so please select one answer. Great. The reason why we're asking this question is because we also want to let you know that not only do we offer these webinars, but we now offer what we're calling community call-ins. And so I'll talk a little bit more about that at the end of the presentation, and also share a handout with everybody. But we have different topics, and it's really a live opportunity, an opportunity for people to call in live and ask questions of our social worker, Todd Gould, or myself, or sometimes we have a guest speaker. And the one that we'll be hosting in October is actually coping through COVID. So thank you for participating in that poll, and I'll just share those results. And as you can see here, about 20% of you are feeling unsure and overwhelmed. Fair enough. 27 feel like you're kind of in damage control right now. 47% are adapting, and 7% are feeling burnout. Yeah, that's totally fair. It's weird and hard times that we're going through right now. So anyway, thank you so much for sharing your thoughts with that. And as I said at the end of Mary's presentation, and after we take questions, I'll go through some of the virtual programs that we are offering here through Brain Tumour Foundation of Canada. All right, so let's get Mary introduced and get going with the webinar. Mary Stuart has been working at Sick Kids in Toronto since 1996. She spent 2 years working with adults diagnosed with cancer in Newmarket at the Stronach Centre. For the past 3 years, Mary has focused her work in the Pediatric Late Effects Program at Sick Kids and at Princess Margaret's Cancer Centre. Mary works with patients and families in the Neuro Oncology Program, the Aftercare Program, and the Bone Marrow Transplant Program. Mary's presentation is entitled Steroids and How They Make You Feel, and this is going to include some information for not only pediatric long-term survivors, but young adults and adults as well. And steroids are often the mainstay of treatment when someone is receiving radiation to help with side effects. And the long-term use of steroids is effective, but can cause physical changes in the body and cause psychological changes as well. So this presentation is going to talk a little bit about body image and steroids and what is known. And so thank you for joining us today, Mary, and joining us during these busy times. And I'll kind of hand it over to you now.
Well, thank you so much for that lovely introduction. I've now been in the aftercare program for like 1 more year, so we'll say 4 years, same population. And I can tell you it's been incredibly stressful for many survivors, and I know there's quite a few listening, mostly because most people are trying to figure out what is their potential risk based on treatment, and that seems to be like the most common question I get. I can tell you that Sick Kids and the Pediatric Oncology Group of Ontario have created really helpful documents to kind of give advice and information based on what we kind of know as of, we'll say, the 23rd of September 2020. And because I also have the pleasure working with adult pediatric survivors, the information that I've learned from my learned radiation oncology expert colleagues has really been that they think that there's more of a risk for someone that is over the age of 50 that has had chest radiation. But if you are a survivor and trying to figure out like what would be your risk, and that is like a big worry or concern, then the last slide has my contact email, and then you can connect with me. If you have a healthcare provider in an aftercare setting, for sure check in with them, and they would be able to give you absolutely specific information based on what they know and based on what they've learned. But how about we just start with the topic today. It's a topic about steroids, and when I say how they make you feel, it's very interesting that how you feel is made up of so many different components, and how researchers and scientists have been able to kind of pinpoint all the different aspects and have incredibly insightful questions to try and figure that out. I'm trying to change this slide screen, but it's not letting me.
If you just click,
hold on one moment
for a second, Mary, it should wake up a little bit. Sometimes it takes a second.
Okay.
There you go.
Oh, there we go. Oh, I'm so sorry. Let me go back. Under the topic of disclosures, I'm not being wooed or paid by any pharmaceutical or any other places. So no financial disclosures. I guess my only personal disclosure is I ate half a bag of chips for my lunch today, and I may or may not be wearing the same jogging gear that I wore earlier today to get to work. And that's kind of the benefit of working in a pandemic when people can't actually physically see you and you're sharing information. But let's talk about the learning objectives today. We're going to talk about, in general, how many different uses there are for steroids. Really discuss the reason why steroids are offered so commonly, talk a little bit about what we know about long-term complications, and then really try and introduce some ideas about how people feel themselves when they're on steroids and what we know. And this is really based on information from pediatric survivors from AYA, meaning 18 to 40, and then people that have had an adult diagnosis of a primary brain tumor. And if anywhere along the way there's any kind of concerns about information, then for sure ask questions. and I promise I'll get to them at the end of the presentation. You know that I work in a pediatric population primarily, and it's kind of interesting to think about like what is the numbers in terms of overall survivors in Ontario in the pediatric brain tumor population. And I know Ontario actually published in 2013 that there was over 10,000 survivors, like all inclusive, all diagnoses. But this is based on 2013 numbers, and it's from POGO. And you can see the numbers of survivors by age group. So you can get an idea of really how many people are in Ontario that have been cured and are pediatric cancer survivors. Another interesting thing, just to remind ourselves, in the pediatric brain tumor survivor landscape, is that they are doing incredibly well in terms of curing people and people surviving 5 years after their diagnosis. So the green dotted line is really all types of neuro-oncology tumors or CNS tumors. The yellow line is patients diagnosed with ependymomas. And the purple is the patient survivors that have had a medulloblastoma diagnosis. And I'm so sorry for the young adults and the adults. I do not have those numbers on the slides, but if it's important, then for sure email and I can get you the stats. So let's talk a little bit about steroids. Steroids kind of include a bunch of different medications. You can get them by mouth or by IV, but the typical names you hear describing steroids are the medicine prednisone, IV methylprednisone, and in the adult world, most commonly the steroid used is dexamethasone. But all those drugs possess strong anti-inflammatory properties. And they really help when people have a need to kind of modulate the immune system. And they're also used in the backbone of a lot of treatments for cancer. And so they really do have a popularity amongst different diagnoses. So then we say, well, what do you mean? So you can use them for allergies, asthma, for people that are having a hard time getting controlled with their puffers. A lot of people with chronic obstructive pulmonary disease benefit from using steroids. There's a lot of autoimmune diseases that actually benefit from using steroids. I told you that there's some cancers that use prednisone and dexamethasone, and for sure it's used when people are getting radiation. So I plucked these pictures out from different advertisements that have existed for a long time, advertising the use of steroids. And the black and white picture with the women on the harp, they actually buffering created like like a steroid plus bufferin to try and help with movement. So I have to imagine she has like a rheumatological problem. And there was a surprising number of advertisements in the 1950s that had a lot of pictures of females specifically, very, very well dressed and happily situated in the kitchen. And so it's incredible the appeal for the advertisement and how kind of advertising has changed. The other ad is for a different type of steroid, anabolic steroids, and people are trying to advertise like to try to not use it. And really, I'm only going to be talking about steroids, not anabolic steroids. And then just to let you know that just like that picture was an ad from 1950, that's when they really started using steroids to treat people with brain tumors. And I think what's interesting, because 1950 is a little while ago, is that there was such excitement as a treatment option using steroids. And so there's lots of different papers talking about how helpful it is. And then I think what has happened kind of over time, that initial excitement changed to concern when they noted that there is these various toxicities emerging from long-term use. And that's kind of what this next slide is talking about, that like 30 years later, after being so excited about steroids, the research emerged that, you know, maybe there are some adverse events that happen when someone is on long-term steroids. And it was published for rheumatology and also in the American Journal of Medicine about how people on long-term doses are having more side effects. And I think the assumption was that if someone was on a very low dose of steroids, that the dosing was really well tolerated by the person. But then when they looked at it in the 80s and 90s, they were really finding out that there's both a clinical cost and an economic cost. And what do I mean by that? Well, in the States, they always measure a person's health by the amount of money it takes for them in terms of their hospital visits and how many different times they come with different things to be addressed. And really what they were looking at was the side effects that someone would experience when they were on a long-term steroid. And the side effects are real side effects, so hypertension, bone fractures, cataracts, type 2 diabetes, and people that developed ulcers. So I think what people have felt is that we should really try to minimize side effects. And then more recently thinking, well, you know, should we try and be less reliant on a low dose of a steroid and maybe try to investigate, like, what other options are there? And so then you say, well, if we have all these adverse events, like what are we doing here? Why are we using it? And I always love a picture because it gives you a real idea of the importance of different treatments. So the brain on the right, you can see like a lot of white, almost looks like fluffy clouds. And it looks quite different than the picture on the left, which is not quite as white. Well, what you're looking at is someone with a brain tumor, and the fluffy white appearing brain is before 3 days of dexamethasone. When you see that response, it's on the left, and you just see an incredible reduction in really what was this extra water content. And you see the kind of reduction in that, we'll call it like an inflammation, extra water kind of picture, but you also have a reduction in symptoms. And so when you look at this, you know that it's working, but what becomes the trickier problem is thinking, if you know it works, how can you actually introduce another medicine and like take a chance that you're going to kind of compromise that very immediate effect? And it's also helpful to consider that not every medicine that's out there breaches the blood-brain barrier, and steroids do. And that's why they're so incredibly impactful. And that's another reason why they're used. But let's not just depend on this lovely picture. Let's take a look since about 2018, like what do the experts truly recommend? And there's been a lot of different evidence-based guidelines that have been developed by neurosurgeons, incredible communities of experts in trying to figure out like what does make sense. And what they say as of last year is that if someone has a metastatic brain tumor, then it really does make sense to use steroids in very different kind of clinical scenarios. And ultimately, it actually relieves intracranial pressure. So if you can imagine the brain that we saw before, like it works. What they do say is that the best thing you can do is as soon as you can, like dose reduce. So whatever dose you're starting out with, like try to bring it down as rapidly as possible. But overall, they felt that all ages, dexamethasone was like the recommended choice. And then we look at another group of experts, the neurosurgeons, and they published at ASCO in 2019 recommendations, and there were really 8 guidelines, and they were also for people that had a metastatic brain tumor, and they also agreed the exact same thing, that it's really helpful for symptomatic relief when you have intracranial pressure and edema, and for patients that are symptomatic. And the normal doses that they recommend were most likely doses that you've experienced before. And it's either a dose of Dex of about 4 milligrams or 8 milligrams, and you're on it for several days, and then you're on that half of a dose for several days, and then you're less of a dose until you're off altogether. And then it's kind of helpful to think about, you know, what does the rest of the world feel? And there's been a group called the Response Assessment Neuro Oncology group, RANA, and it was an incredible group of experts from around the world, and it composed neurosurgeons, neurologists, pharmacists, neuro-oncologists, you name it, and they were from the well-known, well-learned centers. And they actually said that they also agree that steroids should be the mainstay of treatment for adults and children, and that they felt that it was super important to try and reduce steroid doses, like half the dose, as long as the person remains stable clinically. So I think what's kind of helpful to think about is the medicine itself. So I think most people would say they feel pretty confident about how prednisone itself works. They know that it leads to a clinical benefit, but in terms of the mechanism of action and how it works, I don't think that's completely understood. They know that it penetrates the brain, and they also know that it has a long half-life, so it's not out of your body rapidly. And I think another thing that's important to understand is that you have these groups that highly recommend the use of steroids, but overall, I wasn't able to find a standardized endpoints. Like when would everyone agree, like for how long you stay on a steroid? When would everybody agree, like when to kind of half that dose? They're not really with every trial, within every schema available. Not every protocol has that in it. It's sometimes in a research protocol like a secondary endpoint, meaning that they want to try and figure out the steroids and how that's helping with the response. But I don't think consistently people have a guide about what would be the best idea for how long anyone should be on a steroid. So what this group did was they said, well, how about we suggest when you should maybe consider stopping, and then suggest different timelines based on different clinical situations. And what they said is, you know, we've suggested this, but we really need it to be validated, meaning that they need clinicians to try and set up a study to figure out if their recommendations are helpful ultimately for patients. So then let's talk about what symptoms are typically seen in steroids. So most people would tell you, if they've been on a steroid, that there's difficulty sleeping, mood changes. They definitely have an increase in appetite. A lot of people, when they have a mood change, it can also be anxiety and depression. It can also cause reflux, GERD. A lot of people, when they're on doses of steroids for a long time, can have a vascular necrosis, like in their big bones, like a hip or their femur, and bone changes. When you've gained weight on the steroids, you can sometimes develop type 2 diabetes, meaning you need to take medicines to control your sugars. I did hint at the weight gain. But many people, when they're on steroids for a long period of time, develop what's called like a cushingoid appearance, and I'll show you that in the next slide. Also, people can develop acne, and the acne may be on the face, it may be on the back. The acne can be like all over the place. Also quite unsettling. If all these other things weren't quite unsettling, which they are, people will get stretch marks. If they've had like some sort of surgery, they can have delayed wound healing. And anyone that's been on a long-term steroid can have this risk of developing a cataract or the lens of their eye clouding, which also requires special follow-up and often surgery. So those are fairly straightforward side effects. But you can also see like severe psychosis in some patients. Some people can get tremors. If you're a pediatric patient and you're started on steroids for a long period of time, you're definitely going to have a decrease in height. When you're on a steroid for a long time, it can suppress your immune system, and you're normally on a different medicine to try and help you prevent you from developing a very specific pneumonia, pneumocystic carnini. When they've looked at adults that have been on steroids and on protocols for different medicines, they actually tried to take a look at, is there a way that we can try and get people off of steroids? And are there some medicines we give people with brain tumors that can allow us to lower the dose? They actually did find one trial where they looked at this medicine called bevacizumab, excuse my pronunciation. It's in the brain trial. And they noticed that when they started their steroids at baseline and they used that drug, that they were actually able to decrease the steroid dose by about a quarter. There's been other studies like phase 3 trials. So really they know the dose, they know the drug, they know the population. And they found using other drugs that they were also able to decrease the steroid dose whilst on these trials. So they're looking at it as a kind of a secondary goal. And I would say there's just not enough information for all different diagnoses to feel comfortable about saying we can actually get away with doing a lower dose right from the get-go, but at least to know that they're doing research on is there a way to try and decrease steroids. For the pediatric population out there, there was also a phase 1 trial looking at how to dose reduce steroids. And phase 1 trials mean that they have a drug that they think might be helpful, never been used in pediatric patients, but probably have been used in adult patients. And they're not sure if it's going to work, but people are interested in trying. And they used this medicine, and I know if I try to pronounce it, I'm not going to do a great job, so I'll spell it. I'll try and say it and then spell it. Corticorilin is Corticorilin, and that's really, it's mimicking a human corticotropin, which is actually in your pituitary gland. So they tried this by mouth twice a day for 14 patients. And when they gave this twice a day, they were actually able to wean some people completely off dexamethasone. And they noted that they were able to wean some people down in dose, if not off, but that all people that tried this actually physically felt better and emotionally felt better, and they actually noted a better sleep score. So know that they're trying to look at this in various different ways to try and figure out, like, is there other things that we can do? But let's go into the aspect of kind of the typical look that you may see for someone that's been on steroids for a longer time. And the idea is the face gets rounder. I think in the pediatric world, I think they used to describe it as almost having a moon face, meaning like a total circle. And what we've noticed is that the tummy gets rounder too. And you also get acne. So it's a very distinct look whenever anyone's been on steroids for a long time. I think I talked a little bit about things that have been tried in the pediatric population. I guess there's like one other helpful thing I can tell you before we move on about how people feel on steroids, is that there was an adult group investigated to try and see if they could come off dexamethasone. And what they found is when they were taking a specific hypertension medicine, that really they required less of the steroid medicine compared to people that weren't on a hypertension medication. So that there is other works kind of in process where they're noting that there's an association between medicines people are on and then effect. But let's talk about like, how does it make you feel? So the most studied population is not necessarily a pediatric brain tumor patients, whether they're pediatric, AYA, or other. There's much more research on patients with Cushing syndrome. And really that's a typical look that most people would have when they're on a long-term steroid. And what they found is that when people are on steroids long-term, that it for sure can change your mood, can sure lead to depression and psychopathology. And that's kind of a big word, maybe a good Scrabble word, but what it really means is that you can have mental health challenges and behavior challenges, so kind of 2 for 1. And that for the people diagnosed with Cushing syndrome, the most commonly diagnosed mental health challenge was major depressive order. They also commonly had body image disturbance, and really it affected profoundly their self-esteem. So then we kind of look at body image and self-esteem, and what I found out from people diagnosed from Cushing's, that self-esteem and body image is so many different things combined, but really just your perception of your own self changes. And the other great Scrabble word would be dysmorphobia. Most people would think a phobia they recognize. Dysmorphobia, what is it? Well, it's an obsession with how severely flawed something is in your body or appearance. And that actually ends up in you not wanting to be in a social situation or an activity, and your self-worth and self-confidence plummet. You feel like a failure. You're not satisfied with yourself, and you just don't feel good about yourself. So then you say, okay, well, that's not quite specific, to me, to my experience. There is some information in the world of patients diagnosed with brain cancer, meaning adults. And it was published in 2019, and even Rowe acknowledges that it's a really understudied population, and that the populations that's really had lots of research has been patients as adults diagnosed with breast cancer, prostate cancer, head and neck cancer, melanoma, GI tumors, and testicular tumors. And what they've learned from those populations is that there has been a tremendous concern with disfigurement and how their body's not working and how they feel about their body. And so then they thought, well, maybe we should kind of take a look about it with our specific population and see what we can learn, knowing that they've developed these tools to kind of look at other populations. And so they really spelled out, like, how should we think about body image? So it's your thinking and your processing. It's how you think about yourself in your physical body and how your mind is working. Do you have a relationship? Are you in a relationship? How do you think about yourself? How do you think about your body? And did that change with treatment? How do you move? And how do you look? Because really body image has been found to be an important concern for all cancer patients. It's really the physical signs of your disease or your treatment is like a constant reminder of having cancer. It can make someone feel frail. And then really when there's been changes based on surgery or based on appearance, it really profoundly impacts how you socialize, and it impacts your general quality of life. And Wilford and her group in 2017 looked at the AYA group. So I think I told you that's normally like about 18 to 40. And they looked at many different parameters of your perception of yourself, how you mentally process, how you physically feel. And really what they were able to kind of figure out was that there's many different themes that emerge. And what they've noticed is that a lot of the information they've had has been from parents. And so that when we're really trying to come up with interventions that are helpful for many different age groups, if there's still family members actively involved in trying to help, that really new interventions and protocols should be designed to include them, because they noticed that a lot of a person's social competence, or how comfortable they feel interacting with other people, are skills that they learn from their family and from their parents. And it's really the key for people feeling totally socially competent. And then the idea is, what are the things that can impact body image in patients that have had a brain tumor? So often people can have nerves that aren't working on one side. So if they smile, only one side tends to smile. Their voice changes, vision changes, hearing for sure can change. That they can have these treatment-related scars. A lot of people, if they have had radiation, cranial spinal radiation, they just don't get that hair back. It can be scanty. They can have, and sorry for using the word craniofacial deformity, but really what I mean is I've seen lots of patients that have come in whom have had VP shunts, all kinds of shunts, and then there'll be areas where they've had previous surgery where it's like slightly sunken in, and they're covering it. And so I think a lot of the work that Ro did looked at how people kind of assess themselves and what kinds of things most people feel dissatisfied about, and then what that means to kind of your emotional state. And Ro did great work because she really looked at people aged about 23 to 74. And the average age was about 48 years of age. And I think about 77 patients were able to try and comment on the things that they really found hard. The one thing I didn't talk about was dysarthria. And who knows why I couldn't get all the words in that slide, so apologies. But this is like a huge component in someone feeling comfortable talking. Forget about all the other important things, but like how you feel about your physical body. If you are talking but nobody can understand your speech, most people would feel pretty hesitant about having a conversation. Often, if the speech pattern is kind of uneven, then that can be pretty hard for people to try and feel confident speaking. Some people, they just can't really talk louder than a whisper, so that makes it fairly hard to have confident conversations. So that really speech itself impacts tremendously. So forget about the physical body, like there's so many different things that make it super challenging to feel confident. And I know there's not too many people that have the confidence if they don't really think they're being understood the first time. Forget about having treatment before. How confident do they feel to repeat themselves and make themselves heard? Because a lot of people may not have like a lot of confidence even without all these other treatment findings. So then the things that Ro found, and I told you the population was average age about 48, but I think you could extrapolate for other age groups, is that people overall felt unattractive. And they noticed that relatively few of the participants reported feeling kind of positive. And there was like a very small number that reported that they really weren't concerned about anything within their body. And I think if you look at other research out there, I think that they would say that patients that have had a primary brain tumor do have significant body image dissatisfaction. And in younger patients, it could be, the people that tend to have the most body image satisfaction are younger patients or patients reporting a larger BMI, meaning their weight may be a bit more generous than their height. The other thing that Ro noted was that there didn't seem to be a lot of difference whether you were a female brain tumor survivor or a male brain tumor survivor. And it didn't really seem to matter if you had had different types of treatment or therapy. So it seemed to be across the board, people were struggling with this. And I say this because what I think is important to consider is that maybe what we should try to focus our gaze on is doing studies that look at clinical outcome assessments. And what does that mean? Well, maybe if we know that people report feeling unattractive, then maybe we should do research that says, well, how about we're trying to look at this drug and see if it actually improves how you feel about your body. So that we should actually link how people feel and then study it with different interventions, but kind of claim it as something that's important, because if a patient or survivor finds it important, like, we should find it important. So really, all these themes are survivor challenges because how you feel, not only about your cancer, but how your body feels has a significant impact on how you feel. And that I'm not sure if that we're actually figuring that out with our clinical visits. Because the types of questions that are asked in different surveys are not necessarily the same questions that are asked in screeners. And I know at Princess Margaret, we have fantastic screeners, but there's a lot of questions that ask about how you feel and kind of can figure out the mental health challenges you may have. But there's no information on how people feel about their physical body or how their physical body is moving and what kind of challenges happen. So I do think that there's room to develop an intervention to try and measure this when it seems that there's a lot of opportunities to design interventions that are helpful. And what do I mean by that? Well, Ro actually came up with some things that she thought would be helpful based on the people that she met. And she thought there should be educational opportunities. There should be discussions on prosthetics. There should be conversations on, is there an opportunity for doing something cosmetically to try and help with appearance. And I'll give you one example. There is one survivor that I work with, based on treatment, did not have one eyebrow. And what the person wanted was the chance to have an eyebrow. And there's lots of different technology that's out there to try and help with that. But the one that seemed to make the most sense was tattooing. There is, I've lost my thought. There is a place, and I honestly think they're in Peterborough, that offer cosmetic tattooing for different areas. Because as you can imagine, there's different parts of the body that people want to try and kind of bring back to the way it was before. And I'll give you another example. So an eyebrow is one. Another, more commonly, are people that have had breast cancer, had mastectomies, and then are trying to recreate their breast. And you can actually do that through tattooing. And that's just like one example. But in terms of other interventions that we need to think about, are body treatments, strength training. Something that really helps in the mental health landscape is cognitive behavioral therapy. so that there's opportunity for a lot of different interventions to be trialed and tested. But let's talk about body image itself, because a lot of people kind of want to know, like, how do they figure out what is covered in thinking about your body? And so normally, like, there's 10 different topics, and each topic you can rate from a 0 to 4. And if you get a mark of 10, then that means you're feeling some distress. And normally these things are rated out of, I think, 30. And so there's a couple of different topics that most people would probably not feel happy about. The one thing that I noticed, and it's probably because I grabbed it from a female study, is that it does talk about less feminine. For studies that have male and female participating, there's a way to try and figure out how people particularly feel about their physical body. And then I thought something helpful to bring up, because there's so many different ways that we can talk about how we feel about our physical body, but something that happens as a young adult, as a teenager, is that we also think about how do we feel about our physical body, and then a part of that is relationships, a part of that is sexuality, and there are some treatments that can cause not just fertility problems, but kind of changes within the sexual organ function. And I'm not going to take a deep dive into all those different changes, but I can tell you that it's being looked at right now. And I really found the study incredibly exciting. It's being done in Sweden, and they did 2 pilot studies to try and figure out how people feel about their body. And it's the first study that I've seen that wants to include people that have had primary brain tumor as their cancer diagnosis, really before. Most of the light, I guess, is shone on people that have had breast cancer, testicular cancer, you name it, not necessarily brain tumor, but they realized that this is a population that is potentially really impacted. And they are going to take about 2,000 people that have never had a cancer diagnosis, 1,000 female, 1,000 male. And it's kind of interesting to participate in the trial. They'll give you 2 cinema tickets to the local cinema, whether you're a survivor or whether you're someone that has not had that experience. And then they really ask you to participate for a 5-year period. So we're not going to get any information back for about 7 years. It's something that people can call in and do a telephone call. They can do it online. Like, they've really figured out how to make it easy and accessible. And they're also looking at the 19 to 40-year-olds. So I say that because I think looking through the literature the way that I didn't see a lot of information about that. But if you can imagine that you have some negative thoughts about your physical body, then thinking about yourself as a romantic body would be incredibly stressful as well. So I think, oh, sorry, I didn't launch the slide fast enough. But I do look forward to the information they gain, probably in 7 years from now. And it'll be a bunch of different cancers. I think they're trying to do about 200 patients that have a brain tumor or brain or CNS cancer, maybe about 300 breast. And you see what I'm saying? They're going to try and get a representative population from all the common tumors. If you say, well, what can you specifically tell me about what's known about pediatric brain tumor survivors and their self-esteem? Well, there was a really good study that was done by DeRuiter, and she looked at survivors and then compared them to their siblings. And the age group that they were looking at was typically between the age of 8 and 11. This study was fantastic because it also looked for insight from parents and teachers, and that's like a hard thing to do, but more comprehensive in terms of everyone's got their own ability to assess and provide feedback. And what they really found was that there are challenges. Like there's for sure over time, attention can be tricky. The ability to process information can kind of slow down. The memory can change. And that gap between the people your own age group and your abilities can change over time. And there's an increasing gap. And that if we're looking at self-esteem specifically, I would say that is a little bit more scarce in terms of information I can share with you. But that being said, there has been one study that I found helpful looking at social competence. And they did this fascinating study. And they did something that you don't often see, a randomized placebo-controlled, double-blinded trial. And they looked at offering some feedback and then applying different studies to try and evaluate how people feel about themselves. And what they noticed was that people that had cancer, brain tumors, CNS cancers, reported lower self-esteem with school competence. They also found they didn't do so well in gym, and it made them feel non-athletic. And that they noticed that their physical activity and their abilities kind of decreased over time. And so I think when you look at your ability to do things physically, that does kind of impact how you feel about yourself. So what they really said was that small size classrooms and structure was super helpful for patients, and that they thought that there should be about the same amount of structure in the home. They also recommended that it'd be super helpful to kind of screen survivors to figure out how they were doing at their routine visits, and also asking about fatigue and tiredness. And they found that parents were also very stressed out and quite tired. So then there's been lots of looks from the Childhood Cancer Survivor Study, also looking at this as well. And they do know that patients that have had brain tumors do have distress, including depression, fatigue, and daytime sleepiness. And when you have depression, it's like a little trilogy that how you think is negative, how you feel is negative, and your future is negative. There's not a lot of literature in the pediatric landscape for depression and self-esteem and body image. But overall, you could, for sure, there's research that suggests that your body image can impact the chance of you developing depression, anxiety, and challenges coping. And there is literature to say that the depression rates are relatively high and common, and that the best thing that we can do is try and identify things earlier. And then that means like healthcare providers, whether they're family doctors or on their visits annually, have to assess this, which is what we try to do in our center. And then there's also a nice study that was done and published in the Pediatric Journal of Nursing. And they looked at AYA survivors, so 20 parents, 19 survivors, and they did notice that there were challenges in people feeling comfortable talking, socially adjusting, and talking to peers, and that for sure parents were stressed. And when you talk about like what kinds of things were mentioned in this study, they're really awful, like no friends. I don't know if they're ever going to have like a romantic relationship. You know, my child doesn't think she's pretty enough. And that parents continue to be feeling stressed, distressed, uncertain about the current health and future health. I think I've hinted all the way through that I don't think there's enough research on interventions. But I do think that it's something that we should be working towards and identifying how people feel about themselves and their confidence, and that we need to do more research looking at how survivors feel, and then try to think of things that are helpful for survivors, like physical exercise and social interaction interventions. And I'll give you an example. At Sick Kids, there is a cardiology clinic for exercise medicine. And I'm wondering if they have this existing clinic, which sometimes our cancer survivors can be assessed in, like, do we need to think about an exercise clinic for patients that have had a brain tumor? Like, should they have an opportunity to have a very carefully crafted exercise program to try and work on function and then their physical body? I also think that we could actually look at social functioning. And what do I mean by that? I'll get into that in a second. I also do think that we should be doing interventions to offer things cosmetically. I told you about physical exercise and physical function and exercise programs. When I'm talking about social functioning, there's a lot of social skills training that has been already developed and online for people that have been diagnosed with autism. And the work that they've done is phenomenal. Now, not all of it has had the same level of, say, randomized controlled trial research to support it, but they do a lot of helpful things that I want you to think about. One thing that they offer is scripted conversations. And it gets people comfortable talking with, say, a peer-matched group. So pretend that high school students could get 40 volunteer hours helping someone that had a pediatric brain tumor to feel confident about having social conversations. So it'd be like a one-on-one. They'd be skill building with the peer, using information that's already out there. Like, I think that's something that we should be thinking about, because if we know people have an incredible self-consciousness, then maybe we should work at interventions that can help make that something that we can work on. And I do think there's so much information out there that is helpful, that despite it being used in a different population, I do think it might be helpful to look at that a little bit more closely. But sorry, I didn't realize I chit-chatted for so long, but I guess we should try to regroup and see if we can answer any questions.
Hey, Mary, thanks so much. What a wonderful presentation and lots of really, really great information. And yeah, I think, like you said, there's lots of great information out there, but some gaps as well, right? That we need to look at, and hopefully there'll be more research and information available for people down the road. But there's no specific questions that have come up yet, but just one comment from somebody I wanted to share with you. He said that I've recently had 2 seizures in the past 2 months, which was new to me, and looking to find ways to work with my oncologist, neuro, and doctors at the moment. All of your steps that you mentioned are being followed from your presentation, which is very validating and common for him. So thank you for providing those tips and suggestions for sure. I'll give everybody another minute maybe just to see if there's any questions that do come up. Any last words, Mary, that you want to share? Maybe share your next slide so people can jot your email address down. Awesome.
Yeah, it is a lot of information and a lot to kind of think about. But I do think the exciting thing is that there's so many different things that have not been tried that do have a great chance of working. And I think that if there are these programs that already exist, that we have a way of trying to measure it and to try and see if it's helpful. Mm-hmm. So I do feel that there's room for improvement and that we can get there.
That's great. Thank you. It doesn't look like there's any questions, but if anybody thinks of anything, or if you go back and watch the webinar next week, once we have it up and loaded, you can email it either Mary directly or you can email me directly, Janik, and I can include that information in the chat section here. And before we all sign off, I just want to, I'm going to switch you out of presenter mode for a second, Mary, and just flip me over here so that I can share my screen. There we go. So yeah, just before we sign off, I just want to remind everybody that when you go to braintumor.ca, you're going to find lots of really great information. And here you're going to see right on our landing page, we just launched our Hats for Hope campaign, which is an opportunity for you to purchase a toque for $30 and supporting Brain Cancer Awareness Day, which will be on October 24th. So please check out the link here on our website, and you can learn more about this program that we've launched and this fundraiser that we've launched. The other thing I wanted to share with everybody is under the care and support section under virtual programs. This is where you're going to find all the different types of virtual support and educational and information programs that we're offering right now, including under virtual support here. You're going to see more information about those community call-ins that I talked about earlier. So the next one's going to be on September 29th. Next week, we're going to talk about have a back-to-school chat. And then on October 28th, we're going to talk about social isolation during COVID. And then November 24th, getting ready for the holidays, which is really hard to believe that we are already more than halfway through September. The other thing I wanted to show you here is under helpful information at the top of the website. When you click on that, you can order our handbooks and storybooks and resources here. And here is the webinar series. So you'll find the other links to the rest of our presentations throughout the year. And I think I'm just checking my list here. Yes, and at the end here, when we do sign off, a survey is going to pop up for everybody. So if everybody can just take please one moment to answer that. We'd really, really appreciate that. And we're always looking for feedback on how we can do better with our webinars or even just topic suggestions for next year. And that's it. So thanks everybody for joining us today. And thank you, Mary, for joining us. And I know it's a very busy time for you guys at Sick Kids and at Princess Margaret Hospital. So really appreciate your expertise and joining us today.
Yeah, my pleasure. Have a great afternoon.
Thank you too. Take care, everybody.